My name is Dr. Oksana Hamidi, and I am an endocrinologist at UT Southwestern, Dallas, Texas. What we see with patients who have classic CAH is there's definitely a high prevalence of obesity, overweight. We're also seeing high prevalence of insulin resistance, hypertension, as well as osteopenia, osteoporosis, and that also leads to increased cardiovascular, cardiometabolic risk. I am an adult endocrinologist, but looking at the data that has been presented here, we see that as early as adolescence, and that just continues to get worse as patients age. It has to do with their disease control, and it has to do with glucocorticoid regimen, the doses, the exposure, and control of their CAH in terms of the adrenal androgens. So all those factors play in. There are some patients who do well with just glucocorticoid replacement, but the problem is even with very compliant kids, parents, adults, ultimately most patients with classic CAH require supraphysiologic doses of glucocorticoids. So no matter how compliant you are, you're still kind of battling. It's an uphill battle because you are needing to take excessive doses of glucocorticoids, and oftentimes those are longer acting glucocorticoids with more toxicities, longer half-lives, and then also we see patients are needing to take bedtime doses to keep their androgens from surging early in the morning in order to keep CAH under control. So it's just this imperfect, impossible balance that they have to maintain. So again, no matter how compliant they are, they need multiple doses of glucocorticoids per day. They need much higher doses than what's considered physiologic, and they need to take it at times that, like evening or bedtime, that are associated with a lot of cardiometabolic complications and risks. So at end of 2026, my presentation focused on a 2-year data. So we wanted to summarize and show the improvements that were observed not just during the first portion, which is 24 weeks, but beyond that at 1 year, but again, focusing primarily on a 2-year data. And the purpose for this was to show whether the improvements that we see with Crinecerfont are substantial and if they're sustainable over a period of time, that this is not just a short-term improvement and then we see escape. So that was the goal for the study. Also, what we have is most of the studies have short-term data, or if they're real-world studies, there's a lot of selection bias, they're retrospective, observational. So in order for us to do good science, actually, we need long-term, prospective, kind of control type of data so that we can make more definitive conclusions. So the first 24 weeks, that was the first phase of the study when we had double-blind placebo-controlled study, and that was the randomized portion of the study. And then beyond that, patients were switched to open label, and that was up to 12 months. And then the patients had an option to enroll in open label extension. So they continued to take Crinecerfont in up to 2 years at that point. And what's interesting, actually, we saw that more than 80% of patients continued to take Crinecerfont, and we had data, like I said, more than 80% of patients were retained in the study, even that long. So what we observed is that the glucocorticoid dose reduction, which was the primary outcome of the study, was observed pretty quickly, and more so in patients who were on Crinecerfont compared to placebo. And then beyond the 24 weeks, all patients were switched to Crinecerfont, and we saw that even those who were initially on placebo, they caught up with patients who were on Crinecerfont initially. Both of those groups then kind of merged, and we saw that that glucocorticoid dose reduction was observed even at the 24 months. So again, that just goes to show that we are able to impact glucocorticoid replacement in a long period of time, relatively speaking. Most of the patients, actually 71% of patients, were on physiologic glucocorticoid replacement at 24 months. Some of the secondary but important endpoints that we looked at were changes in weight. So we looked at several factors. We looked at change in BMI, we looked at the percent change of weight from baseline, and we also looked at factors like insulin resistance, body composition. All of those factors were taken into account. So if we are going one by one, so first, how many patients lost weight? That's kind of what we are curious to hear. So to make this clinically significant, we looked at weight reduction of at least 5%, because we see that with that cutoff, we see improvement in cardiometabolic outcomes. 40% of patients were able to lose at least 5% of their body weight compared to baseline. So, and this was also, of course, related to glucocorticoid dose reduction. We saw that dose reduction happened quickly, and also it was maintained at 24 months. Another factor we looked at is change in insulin resistance. Looking at insulin resistance of patients who had insulin resistance at baseline, which was determined as HOMA-IR more than 2.5, that was the score that was used. Over 40% of patients actually were no longer considered to have insulin resistance at 24 months. We are finishing some of the data analysis at 3 years, and I think the longest duration of the Crinecerfont treatment was even beyond that, up to 5 years. But certainly the longer we go, just more drop-off, and then also some patients started the study earlier, then the study was stopped because Crinecerfont became available commercially, at which point we just switched to commercial type of replacement.